get the Long-Term Care Academy session kicked off. My name is Jenny Arnold. I'm the Director of Practice Development, and in this current role, I've been taking a lot of the WSPA's lead work on COVID response along with our team and coordinating that. And that's trying to coordinate and work with the state on COVID vaccine preparation and planning. And so I bring some of that knowledge and expertise. I'm also a member of the Washington State Vaccine Advisory Committee that advises the governor and the state on vaccine preventable illnesses, and the Scientific Review Committee for that COVID-19 group, as well as I'm the past chair of the Immunization Action Coalition of Washington. Kathy Bay, who I am so glad is joined us on this call. Kathy, in her training, is an RN, a certified executive in nursing practice, has her doctorate in nursing practice, and she is the clinical quality epidemiology and school section manager for the Office of Immunizations and Child Profile at the Washington State Department of Health. She has been a registered nurse for 35 years and received a doctorate in nursing practice from the University of San Francisco. Kathy works for the Washington State Department of Health, as I mentioned, and has really been working hard on helping with the COVID vaccine response and planning and coordinating within that department, and has been one of the individuals that I've had the pleasure of working with. And just to lead off our discussion, I want to highlight the amazing partnership that the Department of Health has with the pharmacy community. We've been meeting, I've been meeting with the immunization program leaders since I think April or May, every couple of weeks, just to make sure that we, that everything is done to be sure that pharmacy professionals can be engaged in vaccine distribution, similar to how we were during H1N1. And really appreciate that partnership and the plan that has been put in place with the hospital or with the Department of Health. So thank you. Kathy and I decided first it would be great if she could lead off with kind of a review from the Department of Health on where they're at and important key points. And then we're going to open it up for discussion pertaining particularly to long-term care pharmacy and being able to work as a pharmacy community to vaccinate our adult and even children, but those in institutional skilled nursing facilities, adult family homes, and the like. So go ahead, Kathy. Thank you so much for joining us today.
Yeah, absolutely. Thank you for the introduction, and I'm really happy to be here. So I'm going to give you just a brief overview. There's a huge number of slides in this deck, but many of them are just for information purposes. And I would love your questions, both as we're going through this as well as at the end. So I think in general, I'm sure that many of you, again, are tracking some pieces about the COVID vaccine, but just to hit the general highlights and then think about next pieces, is there are currently, I just pulled this off of the New York Times website today. They last updated it on the 3rd of November. And this shows you kind of what's happening along the timeline for coronavirus vaccines. I've heard that there could be as many as 250 to 300 vaccines that are in the process of being tested around the world in different phases. So specifically, there are 11 in phase 3 testing. There are 6 that have limited approval, none of them in the United States. Again, I'm not really going to go into details about specific vaccines other than kind of what we know for vaccines that will be, at least one that we think will be here probably fairly quickly, and a little bit more about detail for that. And so this is actually a slide that's kind of around and has been there, and it shows what the timeline is and potential steps for things. Again, the Moderna and National Institutes of Health vaccine is in phase 3 trials. It is the mRNA vaccine, and it did have government support for the manufacture and delivery, as well as for the development through NIH. The BioNTech and Pfizer vaccine is in phase 2, phase 3. That is the one that is, from what we're hearing, is very close to the purpose of going to FDA for an EUA status. We expect, unless something changes in the process of the last steps of their phase 3 clinical trials, that we will see an EUA at least request for that, and then the appropriate processes that go along with that happen potentially sometime before the end of the year this year. And Pfizer BioNTech actually accepted money for manufacturer delivery, but really they have not done sponsorship or support through the government. Their trial was actually kept as a separate, distinct piece. The AstraZeneca and University of Oxford trial, they are in phase 3. That was a US trial. Also, we're had some phase 3 testing happening in the US that was paused for a period of time and has resumed. And we're hearing from that vaccine that we'll probably see that after the first of the year at some point in the early to late spring. Johnson & Johnson is the same. And then as you keep going down, again, the other vaccines are in phase 2, phase 3. I don't have as much detail about them or track those as well, but I'm sure that there are folks within your community who are tracking and know what's going on with those. Again, for our purposes, we're focused on that piece of vaccine safety and ensuring that we have a good process for it. This slide actually goes through just general information. And again, I think I really like to make sure that people know that even though the process for the vaccine has happened very quickly this year with the COVID virus vaccine, I want to make sure that people know that there are still very specific processes that happen for vaccine safety that are part of the independent review process for vaccine safety. One of them is through the FDA that does the process of the the review of the clinical trials to look at outcomes from the clinical trials, to look at the efficacy from the phase 3 testing clinical trials. That vaccine and biologicals advisory group is a group of experts, and they actually do, again, look at all of those component pieces and then make recommendations to FDA on, should this be, emergency use authorization? Should this be full licensure? Do we think this is recommended? And so that's part of that process. And then after that, the FDA has done their, review of the information from this review committee and makes a decision. Then the next step with it is it goes to the ACIP, Advisory Committee on Immunization Practices. That's, again, a group of independent clinical experts around immunizations, around vaccines, around vaccinology, and they do a second review. They've committed that they're going to do a review of the clinical trials, again, look at the safety and efficacy, and then do recommendations, again, as they always would, on particular patient populations that the vaccine is effective for or not. So I do encourage people to keep looking at and continuing to find information about the vaccines from an awareness standpoint. The FDA review process that I just described, they did a recent meeting on the 22nd of October, and then ACIP met last week. You can look on their website for lots of information about what was discussed at those meetings.
And Kathy, tomorrow morning, we're also lucky enough to have Dr. James Kublin, who will be coming in talking about the vaccine phase 3 trials and the work being done to recruit and engage people from the Fred Hutch's angle. So we'll also get to hear more in depth about the studies going on for the vaccines and that review also from the kind of pre-FDA in that process as well tomorrow.
Oh, great. Oh, well, maybe I want to come to your meeting tomorrow. That sounds fabulous. I think, again, I think the key thing for me, the thing I think people have to keep remembering is there has been a lot of focus, and I'm not going to become political about the process. I should not do that, and I don't want to do that. But what I think our job from a healthcare perspective piece, and I think of this obviously also for the pharmacists who are administering vaccines and who are giving recommendations to patients or providing information to patients, is really making sure that those processes are done, that are the steps, that we're tracking those things to know, and then being an advocate for the idea of, if the vaccine passes those rigorous processes, doing the next steps. So again, great stuff that's happening there. Again, I think the thing that I hear from people is, okay, well, the vaccine is out. Well, gosh, if it made that process, then what's the next step? It just means we get it on the market and we don't keep tracking it. And I always like to remind people that there are ongoing processes that happen for post-licensure or post-release vaccines, and the VAERS reporting system is only one leg of that process. CDC with ACIP has also talked about the fact that for the COVID vaccines, they really are going to have even more scrutiny around the processes of the number of vaccines that are given, any events that occur, all of the monitoring and process work that's happening, and that'll be done by a group of experts. They will report all of that information to ACIP, and then also that will be co-managed again by CDC and FDA. So continued work on that. Last thing with it is, as we think about the life cycle, and again, I just talked about the clinical trials and then talked about vaccine safety overall, but I just want to hit the piece that Washington State, Kathy Lofi, who is the state health officer, did a press release. This was in October. I'm trying to remember what date it was exactly, and I don't remember off the top of my head, but it was in October, talking about the fact that we would be committed as a state under the leadership of Secretary Wiesman, and then also, of course, from the governor's office, in ensuring that we're watching this process and ensuring that there is a safe and effective vaccine that's available, and that it wouldn't just, we would not start planning administration in Washington State, i.e. literally administering, until we knew that those steps were taken and that it was a safe approach to it. And then most recently, last week, I think, the governor's office announced the Western PAC, that's the independent review of vaccine safety. And so Washington State, in addition to Oregon and Nevada, joined California in this Western PAC to do an independent review of vaccine candidates and safety, to look at the process to ensure that, again, there would be integrity around that, and that we would just have a very clear channel to know that, again, the vaccines are safe. Now, obviously, there are times when vaccines are released on the market, and then we find out that there are certain things that, as you get them in more and more a larger population, you can identify that there are other risks or potential groups that it's not effective in. And so vaccines sometimes get pulled. It doesn't happen very often, particularly given the number of vaccines that are administered, but it's an important step to ensure safety of the vaccine and confidence as well. So I don't want to spend a lot of time on these pieces. I really want to answer questions. So lots of stuff in the links for you to have as far as information, and then things you can access and update. This just shows the life cycle of the COVID vaccine. Life cycle on this case is that idea of, what we're anticipating of the vaccine, to look at where we are for distribution purposes. Initially anticipating that we'll have very limited doses of the vaccine. We're hearing that it may be as small as 100,000 or 200,000 doses, and then moving on to that pathway to get to the larger number of doses, and then continued vaccinations strategy shift to look at how do we continue to bring others in to get vaccinated to control this pandemic that's happening around the world. I'm going to jump on to this next slide, and I do apologize, it's pretty small overall. I don't really anticipate that you're going to read the information that's on the specifics of the slide, but I do want to say we are continuing to work to identify our priorities for the allocation based on the phases. And there's actually, at the VAC meeting coming up, I'll lead into that a little bit. We've done a lot of talk at several of the meetings that Jenny and I have been at, and then there's a VAC meeting coming up where we're actually going to finalize planning for that, and then recommendations to the state about how that moves forward. So we expect in the next week or so to really continue to hardwire this process, and then after that, of course, then it will be up to ACIP into taking that information and prioritizing based on ACIP's recommendations for particular populations for the vaccines that they are released. So phase one really is that 1A is really as the national academies call it, the jumpstart phase, and really many of the modeling studies that have been done, in particular looking at information before ACIP, showed that if you can immunize the health workers that are actually providing care to patients, particularly in long-term care facilities and in other vulnerable populations, that you can actually prevent that population from developing the disease, and then you can limit the spread from there. And the modeling studies actually showed that by doing the immunizations in the workers before you immunized the patients, that it was more effective to protect the patients. So that's exciting. And it does, but it does also require that piece of considering that, am I a 1A or a 1B? In that work, why would we segregate and do the employees or the healthcare workers before you would do the vulnerable patients? But that's the rationale behind it. So, and then on from there. So, we are currently doing the provider enrollment as part of the phased approach. And so I know that there's been national work with pharmacies planning. This actually shows, again, we're going to start general enrollment for vaccine, and I'm not an expert about where we are with that work. Overall, I would say I definitely am the clinician when it comes to the kind of the way that we're approaching things, but this does show you a little bit about how we're moving forward with the enrollment for providers. And if you have questions, I'm going to give you an email address at the end that you can link to.
I just talked with Misty last night about this. They're going to be opening up the enrollment for general pharmacies starting on Monday. So there will be lots more information up on the WSPA website starting today about the vaccine and some of this history from Kathy and other great resources so that pharmacies can start to pull together pieces for their enrollment. I think one important piece is that there is no deadline for community pharmacies to enroll as a vaccine provider, that enrollment form will continue to be up. But we'll talk about long-term care here next. But for pharmacies in general, there is no deadline. The health systems have a little bit, they're kind of in that more 1A group and priority group, and that where you were talking about the phased approach, they have a little bit more of a deadline. But community pharmacies in general won't have an end point for their deadline.
Right. So again, in those ideas of the phases, again, we know that the first group of individuals that we expect to vaccinate would be again, healthcare workers, and even focusing again on healthcare workers that are doing higher risk types things. So again, it will depend on what our volume of the vaccine is that's available for us to be able to know exactly where we would be in that continuum. But that's why the focus is we anticipate that most health systems that are larger health systems with larger volumes of staff, particularly, again, we're going to talk in just a moment about the Pfizer vaccine, and that one in particular, because it has a really high volume and it requires ultra cold storage. It's very complicated to think about the idea of how do you not just mix up that vaccine to split it out to different places, but most locations can't manage the overall volume of the vaccine that they would need to store, particularly not in that ultra cold, and then be able to administer. So I'm going to kind of skip over this. This talks a little bit more about the jurisdictional readiness that comes from CDC and kind of planning around that. This is the website for the Department of Health. And again, I know I'm excited that Misty and Jenny have talked, and again, you'll have some work. I'm aware of those things, but I am not as looped in on them. It's not my again, my part of the process is more on the clinical side and doing the other work. So we've talked about the prioritization and allocation guidance, and this is just a placeholder on the slide to have that. I want to talk for just a moment about the Pfizer vaccine, and I'm not going to go into detail about it, although we do expect that it will be the first vaccine that we will have in Washington State and kind of around the United States. But it is the mRNA vaccine, and it is in its last phases of its phase 3 efficacy trial. It requires ultra cold storage, and which is -60 to -80 degrees Celsius, which is incredibly cold when you think about the process. When you think about that vaccine and shipping it, it has to have special handling during the shipment, and there's a lot of work being done to ensure that that there's a good chain of process for the vaccine, that it can be safely managed and shipped from where it's manufactured to all the kind of distribution areas across the United States. But the way I heard somebody talk about it is you have the vial, that's the primary package, that goes into what they're calling a pizza box. that has 975 doses per tray. And then in the trays, then there are 5 trays that are actually inside a larger crate, and it's shipped with dry ice around it. And it requires it to, the thermal shipping keeps it at the appropriate temperature for 10 days. And then you actually have to replace the dry ice to keep it at the appropriate temperature for efficacy, or move it into a more permanent process for that ultra cold storage. And so this kind of goes through the process. Again, there's slides, and I don't know if you've watched the CDC. CDC has ongoing updates on this, and most of that stuff is all public. This is stuff actually from the vendor, Pfizer, who presented at the CDC meeting recently to talk a little bit about it. But again, you know, this goes through the process of ensuring that we are maintaining that dry ice to keep the temperature in the right range, and then storage of it after it's been thawed or after it's been removed from the ultra cold storage. Again, we, Department of Health is working with Airgas as a contractor to think about storage of dry ice. Additional dry ice, we already have a contract with them, but we don't use a lot of dry ice on an ongoing basis. And so we're just trying to make sure that we have a plan and how we're going to manage that. And then thinking about the size and the weight of that thermal container that has those, you know, almost 5,000 doses of that vaccine. I think I always think about it from the clinical perspective of thinking about the vaccine administration. And so what I'm trying to reemphasize with everybody is the infection control measures that are really important. Because this vaccine is a multi-dose vial, but it doesn't contain any preservatives. To me, that means that it's at high risk that if you contaminate it, then obviously the other individuals that got that dose after are potentially at risk from an infection control standpoint. But the second piece with that is making sure, again, that the special handling of the vaccine for the efficacy is there. So it's the infection control component, but then again, that piece of making sure that you're thinking about how to keep that stored for storage and handling purposes. I've added a couple of bullets on here with hyperlinks. One is the, you know, how to get to provider, the list of who in Washington State is authorized to administer and order vaccines. We've had some questions from some different groups about who is allowed to do that. And then standing orders are an easy way, again, for health systems in particular, and for organizations that have staff that are providing vaccinations for them to have, and I left the slide in here. So the Pfizer-BioNTech vaccine, again, it's multi-dose. Each container, multi-dose vial requires dilution. You add 1.8 milliliters of normal saline. And what I'm hearing from Pfizer and from CDC is when the vaccine arrives, you'll get the shipping container with the pizza boxes, but then you would also, of course, get another container that would have all the other pieces that you need, which would include PPE, the normal saline, the syringes, the needles, alcohol swabs, all of the other things that you need that would be the rest of your materials needed for the vaccination.
Yeah,
so,
no gowns, no gloves, no sharps containers are in there, right. But there will be face masks and face shields and the syringes and the vial, the normal saline vials. Yeah.
Right. Yeah. Yeah. So the again, the dilution, once you have diluted it, I think one of the key things that I keep hearing is that it is the vaccine is cloudy. It is actually not just a clear solution. And so when you're vaccinating, you are, you know, you don't toss it out if it's a cloudy solution. That doesn't mean that it's contaminated. So again, one vial has 5 doses, and the correct dose is 0.3 milliliters. But again, that's based on their clinical trial information. We will get the recommendations from ACIP about the appropriate dosing and more information as we move along the continuum of the work. But that's what the manufacturer is saying right now. It is an IM injection, and again, the vial will contain 5 doses of the vaccine. If it's not used immediately after dilution, then it's only good for 6 hours, and it still has to be stored at the appropriate temperature. And before you can even dilute it, you actually have to thaw it because, of course, it's frozen. So this slide actually goes through the steps. And again, the nurse and me and the person who's done a lot of investigation from an infection control standpoint has to keep going back to, you have to make sure you follow, you know, that appropriate aseptic technique in thinking about, that vial when it's a multi-dose vial in particular. So let's see. So I think one of the things I just wanted to spend a few minutes talking about, I'm sure that there are questions, and I only have my last question. My last slide is just a question slide. So, and then the rest of the slides are actually for information for review afterward. But there has been, CDC actually worked with Walgreens and CVS to do a national retail pharmacy plan to approach vaccinations in long-term care. They are specific. If you look at the bullet that's there, it's open to nursing homes, assisted living, and other community-based congregate living settings, but they're really focusing on the fact that they really want to immunize the population of 65 and older. And so we're really trying to continue to do work to consider how do we help support, number one, organizations that are choosing not to go through this pathway to be able to get registered. And then secondly, when you've got a congregate setting, but they're not the population of the patient population or the resident population is not 65 and older, how do we make sure that those individuals have the opportunity? And then just looking through the process of, again, registration. The registration was extended. It's actually open until tomorrow evening, 9 o'clock local time. But really at this point, we're just trying to make sure that we are thinking about, again, how are we going to plan and continue to ensure that, again, this population for the congregate setting for the 65 and older, for our purposes, would probably be in that 1B category when we think about the phases of vaccination. But not all of these locations are going to want to partner with this national retail. And again, we know that you have great relationships, probably already, many of you, with different organizations, and we appreciate that, and they appreciate that. And so just being able to do work collaboratively on that is a really important piece. So this literally is my last slide. And other than, again, there's another 40 slides, I think, behind this. But they're all information purposes for you to know more. And it's really the stuff from the CDC slideshow recently that I will share all of this with Jenny. So I'm going to stop sharing or stop showing my screen.
Well, actually, could you go back to the 1A and 1B, those priority groups? Because I think that will drive some of our conversation here. And one of the questions I got, and knowing that I'm on the scientific review committee that kind of has been setting some of these principles for our state, I wanted to highlight some of this. First of all, we're looking at, and Kathy, please chime in with me because you've been leading that group. Phase 1A, when they're talking about high-risk healthcare workers, there's a recognition that there's healthcare workers, and then there's healthcare workers, and then there's healthcare workers, and there's so many different shades with that. When we talk about there's the highest risk, which are those who are working one-on-one with known COVID patients, again, in the hospitals, especially in ICU settings where they may be ventilating patients and causing respiratory droplets, those individuals in particular, those healthcare workers are definitely in that list. And depending on how much vaccine we get, that can involve everybody from those individuals to then anybody kind of working in general with COVID patients, those who are working in environmental services, housekeeping, anybody kind of working in where they could be exposed to COVID. And down the line, also primary care providers, pharmacy workers, pharmacists, pharmacy technicians, all of the different individuals who could be exposed. In particular, by the time people are giving the vaccine, they are planning is to have those healthcare workers vaccinated, so that one, you are protecting yourself from those large amounts of populations of people that you're interacting with, but two, so you can really help to model that behavior, I guess, and say, well, I got it, and here's what I experienced, and not, I think, feel for all of us to feel better about providing the vaccine, both in terms of knowing that experience and being able to share that with patients, because that's so powerful from a vaccine hesitancy as well as a protecting healthcare workers point. So we don't know exactly with 1A what that reach is going to be able to be, if it will be primary care providers and pharmacists and pharmacy workers, how far out that net will go. We have different contingency plans, but do know that, the critical workers in those different settings, in hospitals, in long-term care are included. And in long-term care, also in particular, knowing that it's the healthcare providers, but also others that could be exposed in those settings. So they're all included, and it is a broad interpretation that we bring to that work. So that was one question that was brought up when we talk about that, and I know everybody wants to know where pharmacy fits into that. Are there other general questions before we get into specifically the long-term care piece? You can either raise your hand or type questions. I'm not saying I'll keep my eye on the question bar here, but we know that you also had the slide on here, Kathy, about HHS, and they put out a survey to long-term care facilities, which include skilled nursing facilities all the way down to adult family homes, for them to select by tomorrow how they plan to vaccinate their population. The federal government has put together a contract with Walgreens and CVS pharmacies to have their staff go out into those facilities and provide vaccinations if the facilities choose, or the facilities can work with their existing pharmacy to receive vaccine and to vaccinate their population. And so we've been encouraging our WSPA members to reach out to their skilled nursing facilities and adult family homes to develop a plan with them. Just so they know where they can help and what those limitations are. Some independent pharmacies and long-term care pharmacies have the staff on hand to go out and to vaccinate those facilities and help to supply the vaccine. And others, getting into every adult family home is just not feasible. So there's flexibility there, and that. One question I get, and Kathy, I'll let you chime in on this, is what is the cost of the vaccine?
So the cost of the vaccine is to the individual is free. So the federal government has said, and my understanding is and I'm pretty sure I will state this, but I will caveat that I'm not positive. At this point in time, there is no cost associated. The federal government has assumed all of the cost for the vaccine, and then also for the idea of the administration process. So from that means that a pharmacy that enrolls in this program would receive the vaccine and the supplies that we've talked about for free. They could administer the vaccine, and then they would either bill Medicare or Medicaid, whomever, from that standpoint. But even if the patient or the individual doesn't have any type of insurance, then they would still, then there's a fund that's been set up the same way it's been done for the point of the testing processes that would provide a fee back that would be the administration fee to the pharmacy. So that's how you would support that piece of vaccination for the patient. And then again, no cost to you out of pocket for the vaccine or the supplies, but of course for the resources needed to be able to administer.
And HHS did say that they have the requirement that insurance plans pay for administration for the vaccine also, which is what we saw during H1N1 as well. The exact mechanism of billing medical insurance versus the PBM side, we're still working on details on. I don't have great indication from the pharmacy community exactly which way that will go. I'm thinking there will be a lot of different solutions for different populations there.
Right. Yeah, and I think the key is right now, as it stands at the federal government perspective piece, again, what I've heard from CDC and posted in HHS is, again, that every individual in the United States has the right to be able to be vaccinated. It's not a mandatory vaccine. And just as a reminder, as long as it has an EUA status, it cannot be mandatory for any individual for it's a requirement for employment or for any other purpose. But once it gets full licensure, again, then you get into, again, those are diverse across the US, but in Washington state, the only employee requirement, again, there can be employer requirements, but the only government requirement is that MMR or the measles. verification process for childcare workers. So everything else is based on employment process for the employer who is defined. And we see that a lot in healthcare, where there'll be requirements of the contingent for an employee to work in an organization. So.
Yeah. One of the other questions is around Valerie. Thank you. She asks, do you see having 5 patients ready to get immunized at the same time? And I don't see lining up, 5 different people so that you can inject them. But what I picture happening is that you pull the vaccine out, what you plan to use for that day, and move it into the refrigerator where it can be stored for up to 120 hours, I believe, in the refrigerator. So you'll have some vaccine that's kind of thawed and ready in the fridge. And then I'll have to go back through my slides. Yep, there it is. Can be stored in the refrigerator for 5 days. So you have the dose thawed and ready, and then you reconstitute 1 vial, which has 5 doses, and draw those up. The post-dilution use is 6 hours. So you can reconstitute a vial and then go in and draw up the dose at the time you administer it. So luckily, you don't have to have all the patients lined up right there to inject all 5 at once. You do have some breathing room with this dose. I think that's also especially helpful in thinking about doing mass vaccination clinics or drive-up clinics where you can kind of do it in a way that spaces people out, but does allow you to, reconstitute the vaccine and then bring it to where you're going to vaccinate patients in kind of a massive, rapid way to really help to facilitate that. So Valerie, thanks for that great question. And Kathy, I'm seeing lots of comments on thank you for the great presentation and for sharing your slides. So just to pass that along, I'd like to open it up for the pharmacy community to chat and ask questions and talk about, what plans have you started to make with your long-term care facilities? What approaches are you having to that? And then Kathy, I think, do you have questions of the pharmacy community with respect to long-term care and anything from your angle that would be helpful?
I think I'd love to hear from the perspective of, and I know that some long-term pharmacies I have heard will actually provide vaccinations, and others do more of the process work of they provide the ongoing support for the supplies that need to be delivered from a pharmacy standpoint, and then of course will manage medications and that kind of stuff for particular patients, but don't necessarily vaccinate. So I guess I'd like to know what capabilities are out there for different pharmacies to understand. Again, if you have a relationship already with a long-term care facility or organization, what partnership you can bring to that?
Yeah, and one of these questions, Mike, you had a great question or thought is, right now the minimum shipment is about 1,000 doses, 985, whatever one of the flats are, one of the pizza boxes flats are for the thermal shipper. And so with the 975, thank you. And one of the challenges
I'm sorry. I was just going to say, one pizza box is 975 doses, but in that shipping container, there are 5 trays. So it's almost 5,000 doses.
I thought they had it as a minimum of 1 tray in each box, but.
Yeah, they said that in the future, their plan is to do that. But right now, at this point in time, I don't think they're intending that would be the approach. It does say, yeah, it says one tray minimum, but I know I've heard potentially that it may be less than that, that you may not be able to do that. Again, it depends on what phase with the vaccine coming and some of the component pieces. And again, we don't really know where that's going to go right now. So.
And I also know that they're working on smaller shipping boxes too. So right now, unfortunately, we have this not very, this very kind of rigid vaccine that we think is going to be the first to market. The minimum doses for the other vaccines that are expected to come out are going to be 100. And we have tried to start already planning ahead and discuss how this works for a pharmacy that doesn't have 1,000 patients right now, but does serve adult family homes or long-term care facilities, and trying to make sure that, one, we don't jostle the vaccine. It's a very fragile vaccine, but yet we work on supply chain issues. So I would say I have no answer, but I am very aware of that challenge and the need to address that to be able to serve our populations in all the ways that we need to. For instance, shipping 1,000 doses to a pharmacy in a very rural area when you're only supposed to be vaccinating, 1A or 1B populations is also kind of likewise challenging, or a rural access hospital that doesn't have 1,000 patients or staff. So we're aware of it. I don't think we have good answers at this point, but it's on our list to kind of troubleshoot and problem solve and figure out for the good of the order. So stay tuned on that. Another person asked, how long can the tray be maintained at -60 degrees? What is the expiration date? I don't think anybody knows what the expiration date is with proper cold storage. I haven't heard any. I don't think they will be sitting long enough on shelves to reach that expiration date. I think everybody's planning on getting it from the shipping box and into patients' arms as soon as possible. You can, as you see here, you can store the vaccine in the thermal shipper, or you can store it in ultra cold storage because they know just a lot of people don't have ultra cold storage at their sites. Many hospitals are having discussions with their lab and with their surgery areas that do biopsy samples for storing vaccine, and being able to identify some freezer space that's ultra cold storage there for that. So lots of ongoing challenges with this presentation, but as Kathy led off, that this is only one of the vaccines. Unfortunately, it's the first vaccine to come to market, so we are going to have to figure this out, but we anticipate in spring of next year having vaccines with much more customary storage requirements that will be easier for when we get into phase 2 and phase 3, which is really where we see the vast majority of community pharmacies receiving vaccine in that phase. Probably late first quarter, maybe early second quarter, maybe by the end of the year next year, maybe. You need a looking glass to know that. But hopefully that will, we won't just have the Pfizer vaccine to contend with. We'll have a more flexible formulation to help vaccinate populations. Other questions, and I haven't heard from sites. Have you been talking with your adult family homes and long-term care facilities? What are some ideas that you have been troubleshooting and discussing with them around that? I see many great long-term care pharmacists on the phone here, so I'm seeking out some folks to raise their hands or chime in with how the conversations have gone on their end. Oh, you guys are quiet today. I'm not used to this group being quiet. Oh, Valerie, you just need to raise your hand if you want to speak. Many of you are unmuted. Valerie, go ahead. I just unmuted you. You're self-muted, so you have to unmute yourself on your end.
Oh, I would think that, I was wondering what kind of records you're going to need about the patients that you administer to.
So CDC is established. So when you do the provider enrollment, it'll go through the requirements of the what has to be documented. And depending on what phase you're in with the initial vaccination or later, depending on whether all the codes are done and the records and stuff. Again, there are a couple of different systems that we're trying to get up and running. One is the IAS, of course, but being able to make sure that it gets documented appropriately. And I think I saw on one slide that it's like 120 fields that have to be documented to verify that you've vaccinated. And then again, of course, most of the, at least at this point in time, the Pfizer vaccine for sure requires 2 doses. I think the second vaccine that's coming down the pipe with the Moderna also requires 2 doses. And so you have to get the same vaccine both times. So it's just making sure that you have a process for that.
So yeah, the immunization information system is one of the main systems in our state. And so if you haven't kind of started to think about how to connect your pharmacy software system to the IIS or to access that, reach out to me, and I'm trying to help troubleshoot as many folks as we can with those access issues. Many software vendors have been working on that with their pharmacy dispensing software as well. So there are opportunities through multiple vendors for reporting to the immunization information system. And every patient is, you're going to be required to give every patient a card, a COVID card. That's also part of the shipment that's coming through, is a card that identifies which vaccine they got and what date. And that is because the 2 doses are going to be required for immunity. And I've even heard that you need kind of 1 dose, and then that actually it's more the second dose that really gives immunity, especially for this one, is what I've been hearing. Just the nature of the immune system is that one's a primer and then the second dose is actually the one that gives you real good immunity, unlike the measles or MMR vaccine, where I've heard, or which, you know, does have, you get coverage with the first dose and then more coverage with the second dose. But I've heard
how far apart?
21 days apart for the Pfizer vaccine. And then I think I've heard 28 days for the Moderna vaccine. And I'll point out, in the immunization world, there's only minimum intervals. There is no maximum interval. So that's the other thing. It's not like you have to get that patient back exactly 21 days later for the second dose of vaccine. It's after 21 days that you need to get them back for that vaccine. Clearly, we want to get people back in and fully vaccinated as soon as possible. I'm not trying to undercut that by any means, but just that we want at least 21 days between doses. 28 probably for the next one that's going to be released. Great, good questions. Oh, and then Dean, you had a great question. Oh, that was your question, was the time between the doses for the 2. So thank you for that. So then patients will have their own little tracking card also to know which vaccines they got, because each vaccine has their own mechanism of action. So the vaccine doses aren't interchangeable. One COVID vaccine isn't interchangeable with another for that second dose. So that's a little bit of a tricky bit there that we'll also have to contend with as we have more vaccines on the market. Wonderful. I haven't been hearing conversations. I was hoping to hear what some people have done with their different sites to plan ahead, but maybe many of you are planning to reach out to them here in the coming day just to make sure that the facility has a plan and you know if you've been identified. Oh, Mike, you raised your hand. I'm going to unmute you. Go ahead, Mike.
There we go. Okay, now I'm unmuted. Thank you. So yeah, it seems to me the real difficulty in contacting the facilities and the homes is, you know, are we really going to be able to access the vaccine? You know, for example, if you're in, you know, a rural area, the likelihood that you're going to use 1,000 doses in the prescribed group that you're trying to access could be really difficult. There just might not be that many people that qualify, but certainly, you know, if you know were to send 1,000 doses anywhere and you said, okay, take care of these people first, but if you've got other vaccine that's going to, you know, not be utilized, either that there has to be a mechanism to share that, or there has to be a mechanism to kind of work your way down the line and say, okay, now I'm just going to open this up to everybody that's got pre-existing conditions under the age of, or over the age of 65, or maybe I just do everybody over the age of 65, depending on what the demographic is there. Is there going to be that kind of flexibility? Do we know? And is there a means of sharing vaccine between different pharmacy providers.
So what I do know is that we're talking about that idea of the size. That's the process or the challenge, I think, given the size of the shipments, especially again with this first vaccine with the significant burden of storage with the dry ice or ultra cold. So we actually have had some conversation about that piece of, is there a way for us to share, have a central kind of hub area? And I keep hearing about it as, you know, kind of the spoken hub, right? That is there a way for us to have it in a particular area and then be able to distribute it out from there? As Jenny said, the vaccine, at least this one in particular, seems to be very sensitive. It doesn't want you to shake it. It's really particular about how it's managed. And so that's some of the conversation that we're having and trying to plan and moving forward with that. I think as we get a little bit closer and we have a little bit more steps in the process and we have more details, that'll help us make some additional decisions. And again, I think that the Pfizer vaccine is, of course, we're expecting it to be the very first vaccine that we get, but we know that for those other vaccines that are coming, and again, I don't have the details on any of the timeline for all of it, but we expect that the other vaccines will be coming, particularly the Moderna vaccine will be coming pretty closely behind the Pfizer vaccine. And so because that one is easier to be able to manage with that, that may be a way for us to strategize in thinking about that. So that's not a good answer. Yeah, not a great answer, but by the time we're through that 1A group where we're dealing with special populations of, you know, healthcare workers, and again, for most employers of the staff, not all of them, right? But because we've already talked about that piece of, you know, that can expand out beyond way, obviously, acute care. But a lot of those employees may actually be immunized by their you know, parent organization or employer, and then it would be after that we actually by that point may have that second vaccine available.
Well, it's also possible that pharmacists could go out to administer.
Right. And it's just whether you can go through 1,000 doses in that period, but we'll see it. The Pfizer vaccine and the Moderna vaccine are liposomal, so they're coated in kind of almost a cell wall looking structure, a liposome that then gets taken up by the cells, and then the mRNA is taken up and then can replicate into protein bits that look like the virus shell to generate immunity. And so it's kind of an interesting, neat, using your own body's kind of engineering processes to make those proteins. But unfortunately, the mRNA and the liposomes are fragile little beings.
Yeah.
So that's kind of where we're at, and where we don't. I think it'll kind of depend, boots on the ground a little bit. Even the studies with these are being done out of, you know, very set, structured medical centers where they, you know, are sitting right near the ultra cold freezer and following all the processes. So we'll kind of see what the reality of the presentation or the vaccination is. So
are hospitals set up for that, for receiving?
No,
It's just the pharmacies.
They're working on it. They're working on securing ultra cold storage. Like I said, they're even going down into their lab space where the ultra cold freezers are to figure that out. So yeah, and Dean, I don't think another great question is the vaccine sensitive to shaking even when solidly frozen? And I don't believe that's the case. It's once it's kind of reconstituted and thawed, but I don't really know.
Yeah.
One other strategy that we're talking about is that thing of the planning or the arrangement of making sure that when the vaccine is shipped, when you think about these large sizes and the planning for it, is to anticipate how before that a shipment arrives and before, you know, it's on its way, basically, that you have a plan for how you're going to use all those doses. So again, that idea of the mass vaccination clinics for, you know, employers where you've got large groups of people that meet those criteria, and then later in the phase 2, again, a much broader population of people who would be vaccinated, and then of course, again, even further into phase 3, phase 4. And so thinking about that and starting to plan or anticipate how you could support either in your community area or as your organization, how you can do that work.
And I can say that WSPA has committed to helping with a hub and spoke model between pharmacies and coordinating between pharmacies. And, you know, Mike, you being able to share some doses with another pharmacy up the street that's also doing adult family homes, and that's only going, you know, a little ways down and from one from the frozen state and right into a refrigerator or something like that. So we have committed to being a support piece for that if that's viewed as or decided to be an option. And I think it really does depend on how fast we can get the second. I think there's some hope that the second vaccine will be the answer to that, since it can go in 100-dose shipments. But we'll just see. We'll kind of roll with it. We're still a little ways out. We're kind of coming up on the end of the time here. So I want to take a moment to thank Kathy and just pass on to the entire Department of Health staff. You're just been very transparent and easy to work with. And I appreciate that so much from my angle and coming in and doing these updates today. So thank you so much for that and taking the time to join us today. I also want to do a call out for the folks on the call. We're looking for a new chair of our long-term academy to help lead that group and start to arrange more and diverse ways for this group to come together. Usually we do in-person CE sessions a couple times a year, and that's not the most feasible right now. So hopefully we can start to have conversations about, you know, phone calls periodically with long-term care pharmacies and leaders around COVID vaccine, but really mostly around whatever hot topics are most pertinent to you all to discuss and share with peers and learn from each other. So thank you everybody so much. Thank you, Kathy. And then I will go ahead and give you all the code. So thank you.
Thank you very much, Jenny.
Thank you.